femur, proximal, distal and midshaft fractures. Fixation using retrograde and antegrade techniques with titanium elastic nail 10 system for elastic stable intramedullary nailing, ESIN. The procedure for implanting the titanium elastic nail using retrograde technique will now be demonstrated. Upon completion of this exercise, you should be able to identify the femoral fractures which are indicated for ESIN, describe the most important biomechanical prerequisites for safe and stable fixation, explain the technical failures of both procedures which can cause complications, and describe the indications and technique for end cap insertion with the 10. The double frame model illustrates the principle of the ESIN technique. The inner frame consists of the medullary canal containing the elastic flexible nails and the bone, whereas the muscles on the anterior-posterior, medial-lateral sides form the outer frame. Both frames have to be functional in order to provide sufficient stability for reducing and maintaining fracture reduction. The application of ESIN in the tibia is more demanding due to the missing outer frame and the surrounding muscle coverage. The biomechanical principle of ESIN is based on the symmetrical bracing of two elastic nails inserted into the metaphysis. Each nail must be supported at 3 points in the bone. The three biomechanical properties of ESIN are axial stability, translational stability, and rotational stability. 10 system for elastic stable intramedullary nailing, ESIN. The characteristics of the 10 system nails are: the nail tip facilitates nail insertion and sliding along the medullary canal. The nails are available in 6 diameters for all indications and in titanium alloy or stainless steel. The nails have markings allowing direct visual control of the alignment of the nail tip in the medullary canal. 10 end caps are available in 2 sizes, which cover all nail diameters and have sharp self-cutting threads for fixation in the bone, which reduces the risk of nail backout in unstable fractures. Use of end caps reduces the risk of soft tissue irritation, and the end caps are designed to facilitate implant removal. The end caps for 10 are not indicated for transverse and short oblique fractures, as they can produce non-union. The clinical indications for ESIN must take into account both general and fracture-specific factors. The general factors are the type of a fracture, the age of a patient, the fracture location, the weight of a patient, and the surgeon's experience using the procedure. The fracture-specific factors are simple, transverse, short oblique, and spiral shaft fractures, distal metaphyseal fractures, subtrochanteric fractures in younger children, and long spiral and comminuted fractures in combination with end caps. The clinical case shows an 11-year-old patient with a transverse femoral shaft fracture 32-D/4-1. The intraoperative X-ray shows good reduction, fragment alignment, and perfect spreading of the nails at the fracture site. The correct proximal nail anchorage is achieved. The post-operative X-rays demonstrate correct alignment. The 7-week post-operative X-rays show callus formation and full weight bearing is allowed. The clinical case shows a 9-year-old patient with a comminuted femoral shaft fracture 32-D/5-2. A retrograde technique is preoperatively planned using 3.5 mm diameter nails. In the situation that sufficient stability cannot be achieved, a MIPO technique will be used. The intraoperative X-rays show that the end caps for 10 secured and improved axial stability and support the long inner cortex contact of the nail. The 5 weeks postoperative X-rays show correct alignment, bone length, and good callus formation. Full weight bearing is allowed. The 5 months postoperative X-rays show full consolidation and modeling. The 8 months postoperative X-rays after nail removal are shown here. In general, careful preoperative planning, correct choice of implant, and a precise rotational check on the basis of the non-operated extremity are crucial to achieve a successful clinical result. The patient is placed in a supine position on a radiolucent operating table. For larger children, a fracture table can be used. Small children must be secured to the operating table. The injured extremity is extended. Note that free positioning allows better control of the proximal nail position and rotation. The image intensifier is positioned in order to capture AP and lateral fluoroscopy of the full length of the femur. Fluoroscopy is taken to measure the isthmus of the medullary canal. The diameter of the individual nail should be 30 to 40% of the narrowest diameter of the medullary canal. To prevent malalignment, nails of the same diameter are used, ensuring that the opposing bending forces are equal. The required instruments are the awl for 10. The sharp tip of the awl facilitates entry into the medullary canal. The pin wrench, 4.5 mm diameter. The inserter for 10. The inserter for 10 facilitates nail insertion and advancement in the medullary canal, and the orientation of the nail tip in the medullary canal is marked on the instrument. The hammer guide allows controlled blows on the inserter. The combined hammer for 10. The beveled impactor for 10 provides controlled and precise end placement of the elastic nail by showing the specific depths of the holes at the tips of the corresponding impactors. It facilitates positioning and fixation of all sizes of end caps. The screwdriver shaft for end cap for 10. The extraction pliers for 10 provide secure grasping of the nails with the tip of the pliers, and hammer guide use facilitates nail extraction. The cutter for 10 allows precise and smooth cutting of nails of all diameters. It can be used close to the skin without damaging the soft tissue. The tip of the nail is fixed in the pliers and the nail is contoured by hand. It is important to pre-contour the nail in the plane of the tip. In terms of the biomechanical nail properties, good contact of the nail with the inner side of the cortex is essential, particularly for long oblique, spiral or complex fractures where a danger of shortening exists. Pre-bending the nails in these cases is highly recommended. To achieve a good 3-point contact of the elastic nail in the femur, it is recommended to pre-bend the nail to 3 times the diameter of the medullary canal over the length of the bone. Note that both nails must be contoured in the same way, and the vertex of the arch should be located at the level of the fracture zone. Avoid creating a sharp bend of the nail, as this may reduce the effectiveness of the nail. The entry points on the femur should be 1.5 to 2 centimeters proximal to the distal growth plate. In children, this is an average of the width of a finger proximal to the upper pole of the patella. The entry points are marked on the lateral and medial sides, matching the central line of the shaft. The entry points are not on the central line of the condyle. In order to achieve optimal symmetrical bracing, it is crucial that the entry points are precisely matched on both sides of the medullary canal. Clinically, the intended insertion points must be verified under image intensification. Incisions are made on the lateral and medial aspects of the distal femur, starting at the planned entry points and extended distally for 2 to 4 centimeters, dependent on the size of the child. As the bone model has a hard cortex structure, there is a high risk of slipping off the surface of the cortex, causing personal injury. Care must be taken when creating the opening. A 2.5 mm drill bit is positioned at 90 degrees at the entry point and is used to open the cortex. The awl is inserted perpendicular to the bone, and a central mark is made with oscillating movements. The awl is advanced into the metaphysis with full rotational movements. Once the awl has secured a purchase in the bone, it is lowered to an angle of 45 degrees in relation to the shaft axis, and the bone is perforated at an upward angle. The entry point opening must be slightly larger than the selected nail diameter. It is crucial not to penetrate the opposite cortex. When using end caps for the nails, the holes must correspond to the core diameter of the end cap. Clinically, the position and insertion depth of the awl must be verified with image intensification. The first nail is loaded in the inserter. The laser marking is aligned on the straight nail end with one of the guide markings on the inserter or aligned to one of the inserter bars. The nail is inserted into the medullary canal with the nail tip at a right angle to the bone shaft and then rotated through 180 degrees with the inserter. The nail tip is aligned with the axis of the medullary canal. Clinically, the position of the nail tip is checked under image intensification. The laser marking on the nail end indicates the nail tip alignment. This facilitates nail insertion, helps to reduce the X-ray exposure time, and prevents excessive crossover of the nails, also known as the corkscrew effect. The nail is advanced manually up to the fracture site using oscillating movements or with gentle blows on the impaction surface of the inserter using the combined hammer. Note that direct blows on the T-piece of the inserter must be avoided, as this may damage the inserter. The hammer guide is threaded into the impactor of the inserter and tightened. The mark on the threaded part of the hammer guide indicates completion of insertion. The combined hammer for 10 is used with gentle blows to advance or retreat the nail. The inserter is untightened and moved backwards around 5 to 6 centimeters. Be aware that if the distance between the inserter and the bone is too large, uncontrolled advancement of the nail may occur, leading to unplanned bending of the nail. The first nail is advanced to the level of the fracture. The rotation of the nail more than 180 degrees during insertion must be avoided. Clinically, The advancement of the nail is regularly monitored under image intensification. To prevent bending of the nail as it progresses up the canal, ensure that the convex side of the nail tip slides along the inner side of the cortex. The nail will bend as it progresses up the canal. It is recommended to advance the first nail across the fracture zone to stabilize the proximal fragment. The insertion point at the medial side of the medullary canal will be opened in the same manner. The second nail is inserted into the metaphysis and advanced up to the fracture zone. The F-tool can be used intraoperatively to perform closed reduction if necessary. The two arms of the F-tool should be positioned as close together as possible. The protruding nail ends can now function as joysticks to manipulate the proximal fragment to achieve precise reduction. Once the cavities are correctly aligned, the nails are advanced alternately with gentle hammer blows or oscillating movements far enough across the fracture zone to ensure that the main fragments are held firmly. Both nails are advanced as far as the metaphysis. The tips of the nails in the proximal fragment must be correctly aligned in the frontal plane. At this point of the procedure, the stability and rotation must be verified with fluoroscopy. Once the nails are fixed in the metaphysis, it is no longer possible to adjust the rotation. If a nail requires 180 degrees rotation in order to cross the fracture line, the nail must be twisted back afterwards. Orientation of the nail is facilitated by marks on the inserter. Clinically, the final position of the nail's tips is controlled using the image intensifier in AP and axial lateral views. The corkscrew effect, where the nails twist around each other, must be avoided. Once the nail tips in the proximal fragment are correctly located and verified under image intensification, the nails can be shortened to the required length with the cutter for 10, which allows the nails to be cut very close to the bone cortex. The appropriate marked opening cutter sleeve is slid over the nail. The black mark on the cutting sleeve indicates the point at which the nail will be cut. The handle is placed on the cutting bolt. With a firm grip, the handles are moved towards each other in one fluid motion to cut the nail. Excessively long nail ends result in pseudobursa formation and prevent free flexion of the knee. They can also perforate the skin and cause infections. After the nails have been cut in their appropriate length, the corresponding beveled impactor for 10 is used to bring the nails into their planned anchorage position in the proximal metaphysis with gentle hammer blows. In this process, the beveled part of the impactor must reach the cortical bone. This position guarantees a protection of about 8 mm. Slight bending of the remaining nail tip will facilitate later removal. Note that use of the beveled impactor will always ensure that the protruding length of the nail end is correct if end caps are used. In case of insufficient stability or a risk of telescoping of the fracture, use of the end caps for 10 is recommended. In a case of transverse fracture, use of end caps for 10 may lead to non-union. End caps are indicated in unstable fractures, for example long oblique, spiral and comminuted fractures. Additionally, end caps also prevent soft tissue irritation and facilitate extraction of the nail. The end cap is mounted on the screwdriver by aligning the D-flats, placed over the nail end, and threaded clockwise into the bone at the entry site. The threaded portion of the end cap directed towards the bone must be fully inserted. Clinically, the correct position of the end cap must be verified with an image intensifier. The medial nail is cut and positioned in the same manner as the lateral nail. Postoperative X-rays should show an anatomical reduction that would be expected in a child. The nails should be positioned correctly with good distal and proximal anchorage. Depending on the age of the child, immediate passive motion by a physiotherapist or continuous passive motion (CPM) should be started on the first day after the operation. On the second day, mobilization on crutches with toe contact may be possible depending on the pain. The patient is usually discharged after 3 to 5 days. The first clinical and radiological checks are usually performed 4 to 5 weeks postoperatively. Full weight bearing may be started depending on the callus formation. Normal activities and school sport can usually be resumed after 6 to 8 weeks. Clinically, bone healing is verified with X-rays after 4 to 6 months, and nail removal can usually be scheduled after 6 to 8 months. As bone healing varies from age to age, there is no recommendation for nail removal after a specific number of months. Clinically, the periosteum is usually slightly damaged during the operation, and callus is formed around the protruded portion of the nail. The extraction pliers for 10 are used to bend the end of the nail so that it is lifted clear of the formed callus. The nail is loosened with strong blows on the pliers and fully extracted. Alternatively, the hammer guide for 10 is firmly screwed onto the extraction pliers. The nail is loosened with strong blows along the guide with the combined hammer for 10 and removed using soft blows on the pliers. The end cap is removed using the corresponding screwdriver shaft mounted on the inserter for 10. The procedure for implanting the titanium elastic nail using the antegrade technique will now be demonstrated. The monolateral descending technique is preferable for fractures of the distal third of the femur or the distal metaphysis. The descending technique in the femur requires a different procedure as both nails are inserted laterally. To achieve the correct biomechanical configuration for stabilization of the nail tips and the metaphyseal fragment, one nail must be contoured and twisted differently. The clinical case shows a 14-year-old patient with a distal femoral spiral fracture 32-D/5-1. The X-ray shows the fracture and the fixation used for anterior cruciate ligament reconstruction that was performed 2 years ago. The intraoperative documentation shows the correct nail positioning. The end caps are used to prevent shortening. Post-operative X-rays demonstrate the correct anatomical alignment and bone length with the nail tips well anchored. The screw for the anterior cruciate reconstruction was removed through a small skin incision before nailing. The 5 weeks post-operative X-rays show good callus formation and full weight bearing is allowed. Sport is allowed 8 weeks post-operatively. The 6 months post-operative X-rays show full consolidation and modeling. The 8 months post-operative X-ray shows correct bone length and rotation after the nails are removed. The incisions are made slightly below the greater trochanter and extend distally for 3 to 4 centimeters, slightly below the lesser trochanter. The insertion point for the C-shaped nail is located laterally in the middle of the shaft, 1 to 2 centimeters below the physis of the greater trochanter. The insertion point for the S-shaped nail lies anteromedial in the subtrochanteric area, 2 centimeters distally from the first point. The points are separated vertically by approximately 1 to 2 centimeters and horizontally by 0.5 to 1 centimeter. The bone may split during nail insertion if the points are any closer together. The periosteum is removed at the operating area. As the bone model has a hard cortex structure, there is a high risk of slipping off the surface of the cortex, causing personal injury. Care must be taken when creating the opening. The cortex is opened using a 2.5 mm drill bit, directed 90 degrees to the bone at the surgical landmark. The awl is inserted perpendicular to the bone. Once there is a safe grip, the awl is set to an angle of 45 degrees in relation to the shaft axis, and the bone is perforated. The steps are repeated to complete a second hole. The first C-shaped pre-bent nail is introduced through the more proximal lateral entry point. The nail is advanced across the fracture 1 centimeter distally using the hammer. The fracture is reduced with the nail and primary stabilization is achieved. The inserter is removed. The second C-shaped nail is inserted with only the first third being pre-bent through the more distal anterior hole until it has good contact with the medial cortex along its length of curvature. The nail is advanced 2/3 distally using the hammer. In this position, the nail must be rotated 180 degrees clockwise or counterclockwise, depending on its relation to the first nail. And the external part of the nail is bent in a distal direction of nearly 90 degrees, creating an S shape which will provide the necessary inner contact with the lateral cortex at the fracture site and the medial cortex of the proximal femur. The nail is placed in the correct position and advanced into the distal metaphysis respective to the condylar region. The inserter is removed. The nail is further bent to increase pressure against the cortex and provide optimum stability. Once the fracture is reduced, the nail is advanced into the distal fragment of its respective condylar region. If the distal fragment is short, a single perforation of the physis is possible. This does not cause any growth disturbance. The inserter is removed. The nail tips are aligned in order that they are divergent. The external parts of the nails will be cut in the same manner as previously demonstrated. End caps can also be used in the antegrade technique as shown in this clinical case. You should now be able to identify the femoral fractures which are indicated for ESIN, describe the most important biomechanical prerequisites for safe and stable fixation, explain the technical failures of both procedures which can cause complications, and describe the indications and technique for end cap insertion with the 10.